So I'm going to try to outline the talk with these 3 bullet points right here. The first one is really to just describe evidence-based models and disclosing test results. What that means is that I'm going to provide you with kind of a framework in terms of how to disclose, when to disclose, and I think the factors that go into that. I'd like to first start off with just the disclosure of research results. To know this is really kind of to know the history a little bit. I think beginning in the early 90s and since then, there's been a very large push to disclose research results to participants. I think there's kind of that balance in clinical training between autonomy and doing no harm. So I think it's definitely been skewed towards respecting the participants' autonomy and allowing them to know what their research results are. And I want to be very clear that research results don't mean just biospecimens, blood, imaging, things like that. It also includes physical exam findings. If I see someone in a clinical trial that has a left facial droop that started this morning, I'm very concerned. We're clinicians as well. And so you can't just ignore something like that. You have to disclose that that's what you see, and whether that will change, their research visit or not. I think that's something that's actually very important. The health of the participant is actually first and foremost. So the benefits of disclosing really are 3 things. So respecting a research participant's autonomy, as I just talked about, the right to know. I think what you'll see is that a lot of participants kind of mix up a clinic visit with a research visit. So they're not really sure why they're coming to you, especially in people who have kind of dementia or mild or moderate dementia. But there's also in the clinic a push for more and more disclosure of clinic notes, of labs, imaging, all of that. And that kind of spills over into the research realm as well, where patients' expectations are that they want to know what their results are. So, and I think rightfully so, they have a right to know. They're providing time and providing data for your study along with biospecimens. And then the last one is, how could the participant really benefit from disclosing? And this can actually significantly alter, how they manage their life, family planning, financial planning, etc. So I think there are significant implications based on what the research results show. The negative side, though, is, the doing no harm. And this can really come about by disclosing results that are potentially insignificant or not verified. There's something called CLIA certification. CLIA is just an acronym that states Clinical Laboratory Improvement Amendments, which I'll talk about here in a little bit. But whether you disclose these CLIA, non-CLIA certified results or not, I think is a big part of the research results disclosure. And then I'll talk about that in a little bit. There's really 2 points that come about in terms of this push for disclosure of research results that I'll talk about right now. The first one is called the common rule. So the common rule now, you have to specifically put in that individual results will be disclosed or not, either in your proposal or in your IRB protocol, because again, this push of autonomy for the study participant. The second one is this kind of dilemma in disclosing results. There's still a lot of people out there that investigators specifically that don't want to disclose research results for good reasons. They're not CLIA confirmed because the vast majority of research results are not CLIA certified. So that has to play in terms of how confident are you in terms of these results, okay? And also not knowing kind of the significance of it. So for example, in regards to Deborah Rose's project, the epigenetics that we're trying to look for, we're trying to predict 20, 30 years before Alzheimer's disease that they have some sort of epigenetic profile. If they have that profile and that's suggestive of Alzheimer's disease, I would not recommend disclosing those results. We don't know the significance of it, and it's definitely not verified. So those are the examples that I think of when I'm trying to decide whether to disclose or not. And that leads me to the general principles of disclosing results. And the first one really is something that is not really talked about, but I think that is actually quite important, is understanding the study participant. You know, in my field in dementia research, we actually get to spend a significant amount of time with the participant, either through neuropsych testing, the neurologic exam, etc. In other studies, it's less common to do so. If you're doing only an imaging study, or if you're only doing a blood draw, there's very little time to interact with the patient. And that's actually very important, because knowing the patient, knowing their preferences, their values, their needs, that will kind of shape their decision-making process of whether they want specific research results disclosed or not. You know, I think keeping that in mind and knowing the patient as much as possible, it's difficult in some research studies and less so in others. So I think really keeping that in the back of your mind when you're trying to disclose results is, how well do you know this participant? The second general principle I kind of think about is objective disclosure and then accurate interpretation. So there's a lot of objective measures out there that we see now that we can do. Genetic testing, fluid and imaging biomarkers are very common examples, you know. So knowing how to interpret them once you get them is actually just as important as telling the study participant, these are the results from your cerebrospinal fluid, for example, you know. And then the accurate interpretation leads to the next principle, which is implications, you know. So now you know the result, you've interpreted it correctly. What does it mean? Does this participant have an oncoming dementia syndrome that you're not aware of, that they're not aware of, and how do you plan for it, which is the last step? And I do want to mention in the plan, though, if you've got some sort of research study that does not have a validated results, I would be very, very hesitant to release kind of those results and formulate a plan based on it. You know, a great example of this are genetic abnormalities. You know, a lot of genetic mutations don't have any clinical significance. You know, so whether you find this or not, and then whether you disclose it or not to the research participant, really goes back to knowing the study participant, knowing this, the interpretation and the implications. You know, if you're questioning the interpretation and implication, I'd be very hesitant to actually disclose those results. So that's kind of the framework in terms of how to disclose results. And now I'm going to go on to Alzheimer's disease and kind of give you examples and work through the principles with the diagnostic results for Alzheimer's disease. So to understand, you know, kind of the results of Alzheimer's disease or any disease process that you're actually studying, you've got to know the pathogenesis. I think understanding the pathogenesis will allow you to lead to accurate interpretation, implications, and the plan. Okay, and I think this will become more clear after I go through the pathogenesis of Alzheimer's disease. So with Alzheimer's disease right now, the prevailing hypothesis is still the amyloid theory. Okay, so based on this, I'm going to walk you through it very quickly. APP is amyloid precursor protein. The I guess cutting of the actual APP protein will determine whether it's normally processed or not. So if alpha secretase is cuts first, it's followed by gamma secretase, that's normal processing. If beta secretase, which is an enzyme that cuts here, if that cuts first, gamma secretase cuts here, forms A beta plaques, and then extracellularly, which leads to kind of the hallmark protein of Alzheimer's disease. You can see all of these proteins or all these medications are aimed at the A beta plaques, both soluble and insoluble. And unfortunately, there has not been a strong disease modifying therapy to date. And unfortunately, that includes the aducanumab that was approved by the FDA in June. Now we go intracellularly, you see these tau proteins that are stuck to the microtubule. If they are phosphorylated, they come off the microtubule, they start forming, they start aggregating together and they formulate kind of these neurofibrillary tangles and then eventually lead to cell death. I talk about this because I want then go on to exploring the three main categories of diagnostic testing as you keep the amyloid hypothesis in mind. Because with that pathogenesis, you can then determine what proteins are affected, how does that implicate the disease, and really able to answer a lot of the questions that the patients or participants, excuse me, will have. So I'll go to the genetic risk factors first. The first ones include the autosomal dominant Alzheimer's disease forms, so APP, BACE1, presenilin 1 and 2. These are the common proteins or genes that are genetically mutated that leads to Alzheimer's disease in patients in their 30s and 40s, okay? And then going back to the most common risk factor for the development of Alzheimer's disease discovered here at Duke, which is ApoE. So ApoE4 alleles places patients at a much higher risk for the development of Alzheimer's disease. Going back to the pathogenesis, now you can see where the genetic mutations occur, and that's why the amyloid hypothesis has such weight and has been the prevailing hypothesis for decades. So APP mutations, amyloid precursor protein mutations, skews the processing to the abnormal pathway and forms A beta plaques. So the BACE1 mutations here causes this to cleave more frequently, leading to abnormal processing. The presenilin 1 and 2 mutations are just subunits of the gamma secretase, and that's how it's involved here. So with this, it will cleave at this site more frequently, leading to the A beta plaques. This is how you kind of have to think about your disease process. It's not just Alzheimer's disease. All disease processes have a pathogenesis that's well established, more so than others, but I think Alzheimer's disease has a pretty well established pathogenesis. So in terms of the genetic test results, this is very important. So understanding the objective findings, what does the genetic mutation say? Is it significant or not? Then you have to interpret it correctly and then know the implications, because especially with genetic testing, this is going to be very important for families, especially young families. Patients in their 60s and 50s, they're always concerned about the family members in their subsequent generations. So their sons, their daughters, what that will mean for family planning for them. So understanding the implications and then formulating a plan in the research study. You don't have to say, and you can't say that you're referring them to a geneticist. Just say that these results, although not CLIA certified, suggest kind of a mutation. That's the accurate interpretation portion of it that has significance, and the implications are that one of your family members might develop Alzheimer's disease at a much earlier age, and that benefits the participant and their family members, because then they can start planning accordingly based on those results. Now, I do want to mention ApoE real quickly in this pathogenesis. I think there's definitely some evidence that interacts with the A beta plaques, both soluble and insoluble, but the definitive interaction is still under investigation at this time. Now, going to the fluid markers, I want to kind of introduce two major categories: the cerebral spinal fluid biomarkers and then the plasma biomarkers. So the all three R38 recipients, I think this is incredibly important for you guys, because once you're done with training, I believe these will, especially the plasma biomarkers, will be commonplace, and you'll see these in your outpatient clinic for the workup of Alzheimer's disease. And so I think one of the projects really looked at, kind of the lab tests and how that kind of affects patients' management. And so the fluid biomarkers really goes back to epidemiologic results from Alzheimer's disease. And I've color-coded these biomarkers on purpose because it correlates with the next slide here. And it just shows you kind of the preclinical AD, so no symptoms right here, but they have the proteins that are associated with Alzheimer's disease all the way through the symptomatic phase right here. And so as you can see, the A beta, the extracellular deposition of A beta continues to climb long before patients are symptomatic. And then what follows along with that is kind of these axonal, I like to refer them as axonal markers, which are tau pathology, so total tau, phospho-tau, neurofilament light chain. They go up at a much slower rate until it ramps up here, kind of this S-shaped, if you will, and that's kind of what causes and correlates well with the symptoms. There are other glial markers shown in green here, and then the newest kid on the block are the synaptic function or density, which decreases, which shows you that there's a lot of synaptic dysfunction later on in the disease course. So going back to nope, unfortunately my talk froze. So I think I'm going to have to reboot. Unfortunately, this occurs at times, but while it's rebooting, what I'd like to point out is that the extracellular A beta deposition is shown in red, and that's something that we commonly look for both in the CSF, and in the plasma. Excuse me 1 second while I get back. Okay. And so you can see that the A beta 42 levels correlate with that red that I had just shown you on the graph before. The total tau, phospho-tau, neurofilament, that's the blue that I showed you for the axonal markers. The glial marker, which is GFAP, tracks well with the green, and the synaptic markers shown here, YKL40, neurogranin, and SNAP25. Those are all very new markers that kind of look for the synaptic function and density. And you'll see those kind of transfer into the plasma more and more as more research continues. So, but that's kind of where you have to know the pathogenesis and then apply those principles that we had talked about, that I just mentioned before, understanding whether the patient would want these results, but then knowing what the specific profile is, because with these fluid biomarkers, it's not just one thing that you're testing for. You're testing for a slew of these biomarkers, and the combination will tell you whether this is actually Alzheimer's disease or not. You know, if they have low levels of A beta 42 level in the CSF, that is suggestive of Alzheimer's disease pathology already starting in the brain, because it's a very sticky protein and it's staying in the brain and leaking less in the cerebral spinal fluid. So that's kind of how you have to think about the pathogenesis, know the objective measures, interpret it accurately, and then know what the implications are. It's not good enough for you to just read the report, because sometimes the report is actually not accurate. You have to look at the numbers themselves, interpret it yourself, and then you'll go through to the correct implication in the plan based on that. Now, I'd like to also kind of go through the imaging biomarkers, and that includes the MRI, amyloid, and tau PET imaging. So for the MRI, it's more of an indirect kind of measurement of Alzheimer's disease. Here on the left panel, this is a coronal T1. The arrows are pointing towards the hippocampi, and you can see that they're shrunken. You know, the temporal horns are enlarged. That would suggest that there's shrinkage there. And then here on the right panel, an MRI, also T1, but it's color coded. You see the arrows are pointing towards kind of the parietal lobe areas, which are pretty atrophic. Okay. Now the MRI brain imaging, the principles I would show here is that if the patient knows and wants to know these results, what I would first say is that, number one, I see atrophy or shrinkage. I try to minimize the medical terminology. So shrinkage in a pattern that is consistent with a neurodegenerative disease. So that kind of brings you through the objective findings and then the accurate interpretation. So this pattern of atrophy would suggest a neurodegenerative process such as Alzheimer's disease. That's the implication. So now that the Alzheimer's disease is set, what is the plan going forward? Do they want to go into additional clinical trials such as the Duke UNC ADRC? Do they want to go into other clinical trials that are investigational drug trials? Or do they just want to start Aricept? You know, giving patients options is the biggest thing that you can do right now in dementia research, until we find a disease-modifying therapy. And this actually holds true with the amyloid PET imaging as well. So Dr. Doraiswamy, who's in the Department of Psychiatry, he did this work that looked at A-beta amyloid PET scans in patients who were positive for A-beta. So you could see people who are negative, there's not a lot of uptake. And the uptake is really shown by increased red signal. And it's best seen here in the A-beta positive group. So the CN is just cognitively normal. There is some signal in the frontal lobes, but in the mild cognitive impairment, you can see that it's starting to go from the frontal and the parietal lobe regions. And people with AD, it's a much darker red signal. I do want to be very clear, amyloid PET imaging is kind of a qualitative answer. It's a yes, no, that's it. We can't quantitate what the amyloid shows us just yet. That's more for CSF results. And so I think knowing this, you have to tell patients that the radio tracer against amyloid is binding. That's the objective finding. And then the accurate interpretation is that the amyloid protein is very suggestive of Alzheimer's disease. That's the implication. And then the plan going forward, as we had talked about before. And then this also applies to the fludarabine, which was the new kid on the block too. This fludarabine was just approved by the FDA last year and is used to actually determine the accumulation of phosphorylated tau in Alzheimer's disease patients. So you can see here in the control panel, not a lot of accumulation. At best, some areas right in the frontal lobe. That's typically just kind of a control region of the thalamus. But in the Alzheimer's disease patients, you see that there's a significant accumulation both of the temporal lobes and of the parietal lobes. And that's very characteristic of Alzheimer's disease. Temporal parietal lobe pathology kind of builds up in there. And specifically in the medial parietal lobe called the precuneus. And you can see that bilaterally. So again, the accurate interpretation, the objective interpretation is that this fludarabine radio scanner is accumulating in the brain. The accurate interpretation is that this, and if their amyloid is positive, is suggestive of Alzheimer's disease neuropathologic change, or simply put, Alzheimer's disease proteins that are building up in the patient's brain. This is suggestive of the diagnosis and then formulate a plan going forward, that is what I would recommend in terms of disclosing research results for patients in the research setting. So just to summarize, I think as long as you can balance a patient's autonomy and do no harm, those two concepts, in the context of knowing the patient, knowing their preferences, knowing their personality is going to be really help you determine what you disclose in the research realm versus what you do not. And then really understanding the pathogenesis of the disease really helps you get a comprehensive view of the disease that you're studying itself, but also instills confidence in the patient that you're talking to. If they have questions that you're not able to answer, they're going to question whether these results are valid or there's other things that are just missing right now. So I hopefully that is a helpful kind of framework in terms of disclosing these results. These are my references, and I'm happy to take any questions. I'd like to also thank Dr. Heather Whitson and the entire team at the Duke UNC ADRC.
So you were saying that you're anticipating that the plasma markers will be more common in kind of more clinical care. Is that kind of where you see the future going, where we'll be actually doing kind of those plasma markers in clinics and things like that?
Yeah, I strongly believe that, so plasma biomarkers are well established now, so I think in the next 2 to 3 years, they'll be validated and they'll be ready for use for primary care physicians. And so I think the primary care physicians really have to, I guess this is more the clinical setting, not the research setting, but interpreting those results and knowing the implications from it, because the p-tau levels can be elevated for various other reasons. And so they have to be aware of that. I'm also looking with Deborah Rose in terms of what causes falsely elevated p-tau, because that not always represents the neurodegenerative diseases, an MI, a stroke, CKD, all of these conditions elevate p-tau. That does not mean someone's demented. That just means that they have elevated p-taus. So,
Okay.
yeah. So I think knowing that's going to be really important for you. And then I think something that's related to Audrey's project is that, can the p-taus and these biomarkers be tracked over time? P-tau is actually probably the best marker for that in terms of cognitive decline and cognitive changes. And then afterwards, when to intervene with specific medications for behavioral symptoms. I think that's kind of where the p-tau is going to be most helpful in that regard. So. But I think there's many other new biomarkers that are still yet to be discovered. So a lot of those synaptic markers, I can't say for sure whether this is actually going to be better than the p-tau itself. So it's an ever-changing field right now in terms of biomarkers.
Sorry, another question.
Please. Yeah.
So for patients, I mean, it's less and less of an issue now that patients are having like a lot of our implants are MRI compatible, but when you have patients that aren't MRI compatible, like in the ranks of important imaging biomarkers that we do, like which ones, if we couldn't do an MRI, like would a PET still be sufficient?
Yeah, so a PET would be definitely, so actually I would prefer a PET scan, amyloid versus an MRI, because an MRI is kind of indirect, whether there's atrophy or not, the amyloid or tau PET scans look at the pathology based on the amyloid hypothesis, but the problem is you kind of have to factor in kind of the insurance issues, and PET scans are not covered by insurance. So the fluid biomarkers are, and so I think that's actually more accurate than the PET scans. And so I tell that to the patients all the time in the clinic is that, the PET scan is less invasive, but it's far more expensive, and so I think knowing that is going to be really helpful going forward. But CSF is probably the number one right now until the plasma biomarkers are validated and ready for use in the clinic. So.
Okay, so the fluid biomarkers that are covered by insurance right now are mostly the CSF ones, or are they both?
No, just CSF.
Just right CSF. Now. Okay.
So I think they're trying to validate it right now. I mean, there's new biomarkers that are coming out of the plasma all the time, and so it's just kind of a rolling, I guess, discovery of these biomarkers. So,
awesome. Thank you.
Sure, of course.
I have a related question regarding kind of the rapidly changing landscape of these biomarkers and imaging results. So, I mean, we discussed how you may kind of hold off on disclosure of kind of these variants or results of unclear clinical significance. But again, given the kind of rapid changes in knowledge, are there certain kinds of frameworks or standards for disclosure kind of after the initial visits or the initial study with regards to access if additional information regarding these variants comes about?
Yeah, so I think what you have to focus on is how novel is this biomarker and what are the normative values? Because even during my fellowship training, which is only a few years ago, we didn't have a normative value for the A beta 42 levels, so it's difficult for us to determine, which lab did you use? Because nothing was standardized, I think that's less so now. So I think that goes back to the theory of, the validation, is this CLIA certified? Is it not? If it's not, how long has this test been around? CSF test results have been around for about 10 years. And so they're well validated, well established. If they're abnormal and that profile is actually suggestive of Alzheimer's disease, I think I would be comfortable disclosing, objectively disclosing them and accurately interpreting them. I think it's the accurate interpretation that's the trickiest with novel biomarkers.
I guess the question is more for the ones that wouldn't necessarily be CLIA certified yet. Like, is there a process for future disclosure if kind of at the time of collection and results being known, they're not CLIA certified, but let's say like a year or two down the road, there's now CLIA certification of like a different kind of a test, and there's kind of more validation with regards to influence on clinical outcomes, and what do you do with your initial result?
Yeah, so that's, I think that brings up two scenarios. So If it's a novel test, and that's what clinical research is just really kind of focusing on clinical research and determining new tests, right? I would probably hold off on disclosing those and just say that this is under investigation. We're not sure what the implications are because we're not sure what the significance is. We need more time to determine what that is, and that's what I'd be just very upfront with patients. They're very understanding about that because that's what, if you disclose that this is what the study's about, I think that's totally reasonable to do. On the other hand, with genetic tests, if you have a non-CLIA certified genetic test, and you want to disclose that, say it's a well-established one. So Deborah Rose just gave a presentation about fatal familial insomnia, prion diseases. There's a well-established test in terms of genetic mutation in the prion gene, okay? Now say that is not CLIA certified, but she did it through, the person did it through a research study. If it's well-established, I think it's totally reasonable to say this is what we found, but be very upfront and say that this is a non-CLIA certified result. I'd recommend that you go see a clinician, particularly a human geneticist, to get further testing to get it CLIA certified. That's commonly what happens in research studies. We found this, now get the result CLIA certified to ensure it. I don't think there's ever been a case where there's been discordance regarding that. So the ones in research studies typically show that same mutation, and then they can start getting plugged in with other resources. So.
Yeah, Andy, thanks so much for that talk. That was very helpful.
Sure.
I actually just had a quick question about the plasma biomarkers. So the ones that we know that are validated are the amyloid beta and the tau. And then you also mentioned the neurofilament light chain and the GFAP. Sorry if you mentioned this and I missed it, but are you clinically, are those being used? Do you send off for those, or do you mainly focus on the beta and the amyloid beta and the tau?
So none of them are FDA approved right now. So there are blood tests for A beta 42 and 40 through a private company associated with WashU called the Procivity test. We're about to start offering that here at Duke, but it's similar to the PET scans. So it's offered, but the insurance companies don't cover it. Okay, so it's one thing to have the test there, but it's another thing to protect the patient from financial burden as well. So you have to factor that in as well. But none of the plasma markers are ready for clinical use at this time. They're all still being validated. So it's only for research studies right now. So, yeah.
Thank you.
Sure.
Sorry, I had another question after kind of what Audrey had brought up. So I guess I wonder, with patients when they do these clinical trials and then years later, say some of these biomarkers get recognized and approved, but because they were so novel in the beginning, you kind of didn't disclose because you didn't know what the significance is. Yep. Like, what do you do about that kind of post disclosure where the evidence is now supporting using these, and you can, like, how does that work with telling patients what the results were?
Yeah, so it goes back to that that objective measure and accurate interpretation. If you think the confidence of the accurate interpretation is high enough after several years of investigation, is well established now. A great example of this is the p-tau in plasma. P-tau 217 was just discovered, found to have a strong correlation with Alzheimer's disease, more so than the p-tau 181 that we're using now. Now it's still too new to say it's actually completely validated. So right now, if someone got that, I'd say this shows an abnormal level. We don't have significant or enough evidence to definitively say that this is abnormal and go from there. I'd say in say 5 years, it's well validated. It's actually used in the clinic now. It's CLIA certified. I'd say, yeah, absolutely. Back in the research study early on, it showed an abnormal level. By then, I'm sure they've had additional testing that they can look at as well. But if you're only looking at that one test, yeah, you have to go back to the confidence in terms of accurate interpretation. So,
do you ever have patients like reaching out after trials are done to kind of like raise that question, or like how does that disclosure happen once the study's done?
Yeah, so this happens in like imaging, with imaging studies a lot, like
Mhm.
amyloid or tau PETs, what did my imaging show
Mhm.
5 years ago? Because I'm in a
Mhm.
study now that shows abnormal fluid biomarkers,
Mhm.
and I would again go back to the patient, know
Yeah.
the patient well. If there's someone that wants to know and it's not going to cause them harm, because a
Mhm.
lot of it is just mood disorders. They're devastated by the news that you gave them a neurodegenerative disorder diagnosis, and there's no treatment for it. So you have to be very careful with your words in regards to
Mhm.
when you disclose that. I think it's totally fine that you do that, especially going back to the autonomy thing principle as well. Is that they are part of this study, but they also own it because this is their data too.
Mhm.
And so I think really you'll see more and more, if you haven't already, that people are always asking for results through Epic,
Mhm.
and that definitely spills over into the research. So
Yeah. Okay. Thank you.
sure.